Hello, my name is Dr. Faisal Anwar. So this is a case of phacoemulsification. In this case, there is glaucoma with peripheral discoloration of the iris and the pigment release on the anterior capsule. So it's sort of a secondary cataract, or you can say it's a glaucomatous cataract surgery. By making the port, we will try to dilate the pupil a little bit more. And then we will inject viscoelastic. You can see the pigment spots that are visible on the anterior capsule, and there is grossly visible discoloration of the peripheral iris. Now we will do the routine capsulorhexis in anti-clockwise fashion. Again we will try to keep the rhexis up to the margin of the pupil. The pupil is already not a big pupil, so we will try to keep the rhexis up to the margin of the pupil. After completing the rhexis, we will make another port for the dialer. This port will not be a complete port, it will be a half port, and as I do 3 port surgery, so I will not make a third port to keep the anterior chamber deep. Now we will gently hydrodissect in 2 quadrants. You can see here no wave is visible. It's a mature cataract, and you can say nuclear sclerosis grade 2, so wave is not visible. Now we will try to dial the nucleus, or little bit move it. Here we have moved it from its primary position. Now we will take the phaco in and I'll do the chop. There will be a little bit of pit that I normally make, and by using the second instrument we separate it into 2 halves. You can see here. Again we will make another chop. Now we will remove the pieces with the help of vacuum and phaco emulsification, phaco power. Now we are removing all the pieces by making multiple chops. You have to be very careful in glaucoma cases, as in such cases the iris can come back to its constricted position anytime. As the angle in glaucoma cases are mostly shallow, you can see in this case there is a peripheral discoloration of the iris, so we don't know the status of the angle, so it can convert into an angle closure, and there can be a sudden shallowing of the AC as well. Here you can see we have removed most of the pieces, and now we are removing the rest of the chunks that are left. So we are almost done with the nucleus and the phaco. Now we will remove the cortical matter and little bit of epinucleus that is left. So it's a small piece that is floating, so we will remove it with the Simcoe cannula. Now in this case The only thing that you have to keep in mind is to keep the iris in and not allow the iris to prolapse through the ports. If once it starts prolapsing, then it will be difficult to control it. Now we are removing the cortical matter. Now I will put in the gel and make the third port, as I am habitual of doing 3-port surgery. So now I will remove the rest of the cortical matter. You can see here I am trying not to touch the iris. You can see here the pupil has started to come back in a constricted state, and when we will end up the case, the pupil will be more small, as in such cases it normally happens. Now we have almost removed the cortical matter. Again we will check it if any small chunk is left below the iris. So we will, now you can see this a big chunk is left, so we have removed it. Now we have removed the whole of the cortical matter, and you can see here the pupil is more small, or you can say has come back or coming back to its constricted state. Now we'll put in the gel to dilate the pupil a little bit more, so we can inject the lens. Now we will load the lens in the cartridge that is not visible here. You have to keep in mind in glaucomatous cataract cases that you have to take care of the iris, especially cases with hypopigmented iris. The iris can prolapse through any of the ports and can make the surgery difficult. Now we are loading the intraocular lens into the cartridge. The lens we are using in this case is very thin, or you can say is thin material lens. So what do I mean by thin and thick material? I will tell you in the end of this case. And at the end I will tell you why I was referring to a thin or a thick material of intraocular lens. Now we have almost loaded the lens. So small pupil, we will again check the incision. Now we will inject. You can see we are injecting the lens here. Now once we have injected the trailing haptic or leading haptic, you can see here the trailing haptic got stuck into the injector and the lens has flipped. So trick is try to remove gently through McPherson force as much possible, as much of the haptic possible through the tip. Now we will again push the injector back and move it forward. You can say we are trying to pull it back and this. When we pushed it forward, we have released the capsule. So now we are facing two scenarios here. One, the haptic is stuck, and the other is the lens has flipped. Now we will take one injectors, or one injector with we will take two dialers, and we will again flip the lens. Here you can see, keep it in the pupillary margin, and now we have flipped it back to its normal position. And now we will guide the lens into the bag slowly. You can see pupil is small. Now again we have to use the gel to deepen the AC, and now again we will guide this lens into the bag. Here you can see we are guiding it back. So always remember, thin material lenses, in case of thin material lenses, you have to face two difficulties. One, they got stuck into the dialer, and second, they can get flipped anytime. So you have to flip them back, and you have to release them from the injector. Now the case is successfully concluded, and you can see we have saved the iris. Peripheral iris is saved. There is no prolapse noted throughout the surgery, and now the pupil, you can see the pupil has come back to its constructed states as I mentioned during the surgery. Now we are removing the viscoelastic from the anterior chamber, and we will try to remove as much possible the viscoelastic. You can see the iris margins are floating, so it means that we have removed the most of the viscoelastic. Once the wave of the water touches the pupillary margin and the margin of the pupil floats, it means the gel has been removed. The other point you can note that you have removed the gel or not is when you keep the irrigation aspiration cannula in the anterior chamber, the pupil will automatically dilate and constrict with the water jet. So it means there is no hindrance to the pupil. Now we are checking, or you can say we are removing all of the gel, and then now the margins of the pupil are free to move, and we have removed the viscoelastic. So the case is completed. Now we will try to seal the pores with hydration. Here you can see, so we can deepen the AC. Here you can see the white area of the peripheral iris clearly visible now. This is the discoloration of the iris that can happen with anti-glaucoma drops or with pigment release in case of pigment dispersion cases. So we will inject the air.